Let's talk about ECMO and early mobility in the ICU. If you work in acute care, especially if you're in the ICU, you've probably heard of or seen ECMO at least once. ECMO stands for extracorporeal membrane oxygenation. An extremely simplified and brief explanation of ECMO is that it's essentially the highest form of life support. ECMO is a machine that can do the job of both the heart and the lungs. If you want a better, more in-depth explanation of ECMO, there are a bunch of perfusionists on TikTok. I'll try and tag some of them below. There are two types of ECMO. Number 1, VV ECMO, which is for the lungs and stands for veno-venous. And number 2, VECMO, which is for the heart and stands for veno-arterial. VV ECMO, aka lung ECMO, means the machine cleans the blood by swapping out the gases. It takes the CO2 out of the blood and puts the O2 into the blood. VECMO, aka heart ECMO, means the machine pumps the blood from the heart out to the rest of the body and circulates the blood around. There are typically 2 ECMO cannulas or tubes, 1 cannula for sending blood out of the body and 1 cannula for receiving blood back from the machine. The most common ECMO cannula sites are the neck, the groin, and the upper arm-chest area. Cannulas can also be inserted centrally, directly into the organs, through an open chest. The ECMO cannulas are large tubes with a wide diameter, around the size of a boba straw. The material of the cannula tubing is also flexible and has good compliance, allowing it to freely bend without much resistance. These characteristics of the cannulas make them easier to manipulate without causing much microtrauma to the vessels, which allows for safe early mobilization, including both sitting and walking. Some reduction in flows and minor oozing from cannula insertion sites is expected. Both are dependent on the patient's body habitus and anthropometrics. Evidence shows that early mobility for ECMO patients is safe, feasible, and beneficial. Early mobility includes activities like verticalization therapy in a standing bed, sitting up at the edge of the bed, sitting in a chair, walking, riding a bicycle, and even weightlifting. The cannulas should be properly secured prior to mobilizing. Triple securement is the bare minimum. First, it should be sutured at the insertion site into the vessel. Second, the cannula should be sutured externally to the skin, along the limb. And third, it should be attached to the proximal limb with an adhesive cath grip. Oftentimes, a head strap is used as a fourth method of securement for neck cannulas. Let me know if you'd like a tutorial on how to make the neck cannula head strap. Early mobility in the ICU has many benefits and improves patient outcomes. Research has shown that early mobility promotes GI motility, prevents blood clots, prevents pressure ulcers, deconditioning, and significantly reduces the risk of ICU delirium. Physical activity is an independent factor to reduce mortality in the ICU. Mobilizing an ECMO patient is super challenging. These patients are critically ill. And attached to many lines, tubes, and machines, it's a lot of work for everyone, especially the ICU nurses. The critical care rehab team includes an ICU PT, OT, and SLP. It takes a village, and the typical minimum staff for ECMO mobility is 1 PT, 1 OT, 1 nurse, 1 perfusionist, and 1 RT. Without early mobility, ECMO patients in the ICU become severely deconditioned and oftentimes bedridden, with horrible complications that destroy their quality of life. So, as the medical team is saving the patient's life, the critical care rehab team is saving their quality of life. Do you mobilize patients on ECMO in your ICU?